There are certain topics which we think we know better, but when we go into the details of the topic, then we realize that really we don't know much about that particular topic or the disease. One of those topics is acute rheumatic fever, and in this lecture we are going to cover all aspects of acute rheumatic fever. So basically, acute rheumatic fever is a multi-system disease resulting from an autoimmune reaction to group A streptococcus. You can remember as GAS, group A streptococcus. So acute rheumatic fever and rheumatic heart disease are disease of poverty. So we have a huge incidence of rheumatic fever, rheumatic heart disease few years ago. Definitely we can say at this point in time there is a significant reduction of acute rheumatic fever, and subsequently we are going to see less incidence and prevalence of rheumatic heart disease. So it is in 1600s, Sydenham first described the chorea. So the first manifestation which is described in rheumatic fever is ironically the last clinical manifestation of acute rheumatic fever. So the last manifestation was described as the first manifestation. So Charles Wells in 1812 associated rheumatism with a carditis. He is the one who connected the joint pains to the carditis as well as subcutaneous nodules. 1880s, the connection between pharyngitis and rheumatic fever came through Walter. And 1889, the classic description of acute rheumatic fever came. And it is Alvin F. Coburn in 1931 suggested that the beta hemolytic streptococci is the reason for the pharyngitis as well as acute rheumatic fever in New York. So 1944 is a very important year where the Dr. Jones developed the diagnostic criteria for diagnosing rheumatic fever. So this is called the Jones criteria to diagnose acute rheumatic fever, and of course he presented with the basic criteria to diagnose acute rheumatic fever. Subsequently it was modified with the new information. So epidemiology of the acute rheumatic fever is linked with GAS, rheumatic group A, beta hemolytic streptococcus, pharyngitis. Both have maximum incidence of the age between 5 to 15 years. Very rare before 50, before 5, rare after 15.